All right, so hello everyone, and welcome to our panel discussion, Harm Reduction and Hepatitis C Prevention. My name is Rivka Kushner, and I work at CATIE as a manager in hepatitis knowledge mobilization, and I will be your moderator for this panel. We are honored to be sharing this time with you today and to hear from our panelists who bring a wealth of experience and perspectives on the topic of hepatitis C and harm reduction. Before introducing our panel, I'd like to first acknowledge that we are gathering on colonized lands. Our panelists and audience members are based across the country on the traditional territories of Indigenous peoples who have cared for these lands since time immemorial. The historical and ongoing impacts of colonialism and systemic racism disproportionately impact Indigenous people, directly contributing to inequities in the prevalence of hepatitis C in this community. When it comes to the overarching theme of the symposium this year of preventing hepatitis C, harm reduction is one of the most important and effective strategies that we have. Harm reduction services through safer substance use supply distribution, paired with education and support on safer substance use, prevent new cases of hepatitis C. These services also offer linkage to treatment and other substance use health programs and can be important access points for hepatitis C testing, linkage to care, and treatment. We've always known, and it was echoed this morning as well, that we can't treat our way out of the hepatitis C epidemic. Without expanded and sustained efforts to increase access to harm reduction services, it is hard to see a path forward for Canada to achieve elimination targets to eliminate hepatitis C as a public health threat by 2030. We also really want to keep in mind that harm reduction services do a lot more than just prevent hepatitis C and other STBBIs. They are essential community and health services. They are spaces where people can come as they are, be met with kindness and compassion, and receive life-affirming and life-saving care. However, harm reduction services are under threat in many parts of this country. There have been policy changes, funding cuts, and closures that are making it more difficult or impossible to access services. It is in this context that today's pan-Canadian multidisciplinary panel will discuss what is happening to harm reduction services in various parts of the country, what it means for preventing hepatitis C and for the broader health of people who use drugs, and what can be done to challenge the political winds and to increase harm reduction access across the country. I would now like to introduce our esteemed panel. We have right next to me, Jason Altenberg, the Chief Operating Officer with the Dr. Peter Center in Vancouver. Next, we have Ahmed Bayoumi, a general internist and HIV physician, the Baxter and Alma Reichard Chair in Inner City Health and professor with the Department of Medicine and Institute of Health Policy, Management, and Evaluation at the University of Toronto. Next, we have Doug Belanger, community health worker in the in hepatitis C with the Toronto Community Hep C program, based at South Riverdale Community Health Center here in Toronto. Next, we have Martin Pagé, the Executive Director of Dopamine in Montreal. Then finally, we have Barb Fornssler, an Associate Professor with the School of Public Health at the University of Saskatchewan. To begin our discussion, I'd like to start by inviting each of our panelists to share more about themselves and their work, and to reflect on the current state of harm reduction in their workplace, region, or city. So Doug, kicking it off with you, as a community health worker with the Toronto Community Hep C program, you have many years of experience supporting people with testing and treatment for hepatitis C and connection to other health and social services. What brought you to this work, and how has it changed in the last few years?
What brought me, can everyone hear me? Can everyone hear me now? What brought me to this work was finally getting treated for Hep C. I tried to get treated many times prior, was never successful because the way I got treated, I was always stigmatized and judged for who I was until I came to the Toronto Community Hep C program and met the nurse. And the way she treated me, I knew I was in the right place. I stayed, and I didn't realize at that time it was going to get me into this field. And I have been doing it since 2017. And I love supporting folks just like me. And then that led me to do the treatment, to doing their peer course, graduating, and becoming a worker. Yeah.
Thanks so much, Doug. Can you share a little bit more as well about how your work has changed in the last few years, the differences that you've seen?
Well, when I got into this here, the safe injection sites were grassroots, and they became to 10 sites. And now with the current government, we're down to, I believe, 3 sites in Toronto now, which is making it very difficult for people to get harm reduction supplies. And even with these new sites they call the Heart Hub, a lot of staff that work there happen to come from the safe injection sites, and they find it challenging because they cannot distribute harm reduction supplies either. They always redirect them. Yeah, it's a stressful time. I think that's another important reason why we all need to let our MPPs and send them letters, whatever we can do. I understand that everyone here is on the same page. So yeah, we need to keep on advocating.
Thanks so much, Doug. Jason, you've been having conversations with harm reduction program leaders across the country. How would you describe the state of harm reduction services in general in Canada right now?
In addition to being difficult to get to the mic, it's difficult for, this is a performance art piece showing you what it's like for harm reduction programs right now. No. Maybe we do need a bit more performance art to answer the question, Rivka. I mean, it's been alluded to over the last couple of days that things aren't great for harm reduction programs across the country, and I'm in a uniquely, perhaps a somewhat unique role in that the Dr. Peters Centre, which is a local service in Vancouver, in the unceded territories of the Coast Salish people, it has its roots in the HIV movement, and so much of our work in CanHepC work has borrowed from that movement, and the harm reduction work we do has come out of that movement significantly in terms of needle syringe programs and the range of harm reduction stuff we do. And I joined the Dr. Peters Centre a couple of years ago, just about a couple of years ago now, and part of our work is working with frontline organizations across the country to increase the capacity of those organizations to do the frontline work. So I've had a lot of conversations. I also had the honor to work with Doug and the team and help set up the Toronto Community CanHepC program. So I've seen what's possible when the opportunities are right and what can be accomplished. And so there's a few things. Things are different across the country. So, and nobody, wherever you are, you probably don't feel great about the way things are going. So I think there's a general sense that things are trending in the wrong direction when we talk to people. Those trends are really different depending on where you are, though. And there are a few regions of the country where quietly things are scaling up in terms of harm reduction access. I think, and I actually have some messages from colleagues from some of those places to share today. And that includes Manitoba, and parts of Atlantic Canada. But in Ontario, BC, Alberta, Saskatchewan, Quebec, we hear that people aren't feeling good about the direction things are going. And the slide that was up earlier that showed Canada in that top quartile, but in the bottom part of the top quartile of where things are. And I think there's a feeling when we talk to people that we're slipping. And there's a number of reasons for that. I think that Doug alluded to the policy things that are shifting. And again, depending on where you are, it looks different. In BC, there's been a political shift away from the decriminalization pilot, which is symbolically and practically a big deal. And there still are dozens of provincially supported OPS sites doing work to save lives and get people into care and treatment and attachment to care. So things and that looks really different than here in Ontario, where those things are being actively shut down. And so things, but there's this general sense, no matter where you are, that things aren't getting better or not getting better fast enough to keep up with the crisis. I started my career in Vancouver in the early 90s as a frontline worker, and I did harm reduction work there and then here in Toronto over many years. And in the early mid-90s and into the early aughts, we really did long-term work with people where disease prevention was the main focus of what we talked about as harm reduction workers. And where we had the privilege of not being consumed by just life preservation in the work. And I think that's the other thing we've heard, like over the course of the last 10 years, as the drugs have become more chaotic, and the drugs aren't the same everywhere either. Tamara talked about the shift to smoking that we're seeing in many places, away from injection drug use. That may have, on the one hand, a positive effect on Hep C in some ways. We've heard other people talk about just the massive amount of loss, of death in the community, tens of thousands of people. And that also has perverse impacts on Hep C incidence and prevalence. And so these things are changing, and they're changing a little bit differently depending on where you are. We came out of the pandemic with, I think, a workforce, though, at the front line who are exhausted, vicariously traumatized, are often made up significantly of people who have their own lived experience of the issues. They're not just losing their patients and clients, they're losing their friends and community members. And the reality of staying focused on all of the complex education work on prevention, disease prevention, when you're both feeling traumatized and in a state of grief and loss, alongside just trying to keep people alive, is a hard thing to do. So I think that's the other thing we've heard from people, like, again, over now a period of decades, harm reduction workers had a lot of time to talk to people about why using harm reduction supplies would prevent disease. These days, and with the dope is different. I mean, when I talk to people, the dope is different. Trank dope now, benzo dope recently. The kind of conversations you can have, the opportunities, the moments for engagement are different at the front line level too, as the dope changes. And what you can expect to get out of those interactions is changing. So simply messaging to people not to use alone, to have naloxone, to use where they might be found, those take up a lot of the mental energy of the frontline workers, and on top of that, they're doing incredible work to keep people engaged and retained in care or getting tested somehow. But it is harder to do that a decade into the toxic drug crisis. And in the scale of priorities for community, we heard that too, for people who use drugs, and for people working with those folks, in the scale of priority, keeping people alive has now dominated the work for so long that it's hard to expect people to do all of that at once. I'll stop there to let others people speak, but the political backlash, we'll probably get into that around these programs, is very real and very profound. And it can become, even when a province is doing progressive work, my colleague from Manitoba said, like, we have a mandate letter that says save lives, open consumption sites, do all the things, and at the very local level, it is very hard to implement that, because at the municipal level or the community level, there is deeply organized pushback on these things, even if that's not happening at the provincial level like it is in some provinces. So I'll stop there for now and we can continue the conversation.
Thanks so much, Jason. Great to have some cross-Canada reflections. Going to Martin now. Could you please share some of the political context and challenges you've been experiencing with harm reduction services in Quebec and how it's impacting your work at Dopamine in Montreal?
Yes, thank you, Rivka. Good morning, everyone. Yes, just to say that Dopamine operate different harm reduction services grounded in peer leadership, dignity, and low threshold access. My organization has existed for more than 30 years in a community a bit east of downtown Montreal. I wish I could brought more light in this conference, but unfortunately I can. In Quebec, harm reduction is no longer debating as a health intervention. It is debating as a visibility problem or public security matters. The conversation has shifted from prevention to control, from health equity to public safety. Public discourse is framing people that use drugs as a serious threat, or even worse, as dangerous people rather than citizens. From evidence-based policy to political-driven decision. As an example, in Quebec just passed this Bill 103, which is similar than the bill in Ontario. This reinforced municipal and provincial authorities to limit or block the implementation of harm reduction services like safe consumption site, which is going to destabilize access to care and directly compromise effort to prevent Hep C, for example, and overdose amongst people that use drugs. Because we know that supervised consumption services are also an essential entry point to reach people who otherwise are pretty much disconnected from the regular healthcare system. They, and we cannot, talk about hepatitis C elimination while we disrupt our infrastructure. We are able to connect with people that use drugs. We prevent transmission through harm reduction programs. Thank you.
Thanks so much, Martin. Ahmed, as a physician and researcher in Toronto, what are you seeing in Toronto and Ontario when it comes to harm reduction service access and policy changes?
Thank you, Rivka, and thanks for the invitation to be here. I want to start by actually painting the picture of what things were like a year and a half or 2 years ago, and we had really a lot of interest in implementing harm reduction, and more than that, we actually had a history in Toronto, at least, of very effective distribution of needles and syringes throughout the city that went back decades, and resulted, I think, it's hard to prove this definitively, but Toronto as a whole, compared to other cities of its size, had a relatively low rate of HCV positivity amongst people who inject drugs. It was about 4%. Those are outdated numbers, but the last data we have. That's still 4% too high, right? But it was really I think, a result of very effective, broad-scale harm reduction intervention in terms of needle and syringe programs. But not only that, one of the things that I do when I teach my medical students and residents in my hospital is I ask them, do you know where the nearest needle and syringe distribution site is? We work on the 14th floor, and most of them will guess that it's at Toronto Public Health. And it's actually on the first floor in the emergency department, right? Like it's right underneath us. And the reason I bring that up is that the way that needle and syringe programs were introduced in Toronto was very broad and very much integrated into existing health services. So let's fast forward a bit. Really in the last year and a half, 2 years, we've seen a lot of, as other people have also talked about, reversal and de-implementation of programs. We've seen closure of supervised injection sites on a scale that really, I don't think any other jurisdiction either implemented or de-implemented supervised injection sites on the same scale as Ontario. We've seen closure of formal safer opioid supply programs, both defunding at the federal level and provincial restrictions on this new model in terms of saying that they can't offer safer opioid supply in a programmatic structure. We've seen the federal government deny Toronto's request for decriminalization, and we've seen the Ontario government introduce legislation to criminalize drug use in encampments and to give police extra powers to seize and arrest people who are using drugs in encampments. Just this week, we've seen discussion about giving transit police the authority to increased authority to arrest and people and seize drugs. We've seen regulations being introduced to give landlords unprecedented rights in terms of violating individuals' privacies and seizing their drugs. So we're seeing this whole, not only a retreat from decriminalization, but a hyper-criminalization of drug use. We've seen, and even the needle and syringe programs that I talked about, so these new heart hub models that Doug talked about are not actually allowed to distribute needles and syringes. So probably the single harm reduction intervention for which we have the strongest evidence and which has been implemented most broadly is now actually not being allowed to be implemented. So it's really, a bizarre time. I'll just say we've done some modeling work. So that was the situation. But I do want to stress that even though we talk about supervised consumption sites and safe for opioid supplies, we actually have some data on this. So by our estimates in Toronto, less than 10% of people who use drugs lived within 500 meters of a supervised consumption site, even when all 10 sites were open. So this idea that there were like massive numbers of sites is just not true. They were already not only serving a minority of people. That said, in our work, we estimate that probably more than 50% of people who were within the proximity of a site who inject were actually doing so within a site, which, that's a large number. There was a large degree of uptake at these sites. And then again, with safe for opioid supply, we actually used some administrative data, and we estimate that there were probably less than 1,000 people who were ever receiving safe for opioid supply in the whole province of Ontario. So this idea that this was like a huge number and that this was out of control, also goes in, these concepts are part of the rhetorical discussion around harm reduction, but they're not actually rooted in the evidence that we have. I'll stop there.
Thanks so much, Ahmed. Continuing in that vein, the government of Saskatchewan has made the controversial decision to move to a one-to-one needle exchange policy. Barb, could you please briefly describe this policy and what it looks like on the ground and the health and other consequences that you're seeing or anticipate because of that policy change?
Absolutely, and thank you for the question and being here today. It's really nice to not be speaking in Saskatchewan today just because I don't have to explain the benefits of harm reduction before I get into it. So I'm glad we're all on that same page, and it's nice to be amongst friendly people here. The government of Saskatchewan in January of 2024 made a wide policy change that defunded all supply distribution in the province and returned to a one-for-one needle exchange model rather than distribution. Particularly concerning given that we have higher rates of stimulant use and particularly injection stimulant use in Saskatchewan. So when thinking about how to bring all that down, one-for-one is exactly what it sounds like. I do like that we'd been away from one-to-one exchange for so long that I do have to explain to people that there's a difference from distribution, and this basically means you need to bring in a used syringe to receive a new syringe, or that is the formality of the program. The government believes that this will result in less needle refuse. We already had a return rate of over 97% under the distribution program. So there's a lot of rhetoric that's been going on in Saskatchewan. And I know we're a small province. We're about 3% of Canada's total population. But we are facing a lot of the same harms as are being seen across the country. I wrote down a bunch of notes, but I tend to speak from my heart about things. What we're seeing in Saskatchewan is not only, a sustained attack on harm reduction services. Our supervised consumption site, there are 2 in the province now. There was one for a very long time at Prairie Harm Reduction and located in Saskatoon. That site has never received provincial funding and runs on donation and merch sales. Okay, so there is now Neo Yotina in Regina that is operating an SCS. They started as an overdose prevention site, but are now an SCS, which is great to have that exemption in place. They have also never received provincial funding, so they're funded through the network of friendship centers. Our government has never been friendly to the words harm reduction, and they've been really pushing hard on this idea of abstinence-only treatment approaches as the solution to drug-related harms in the province. evidence shows this is not going to be an effective approach. Most recently, so we had that in 2024, that reduction in all harm reduction supply distribution funding. This was disappointing because we saw a reduction in safer smoking supplies across the province. There are many organizations that have continued to provide safer smoking supplies where they can peel it out of their budgets in some other way or from some other project or through donation. They also tried to classify syringes and fentanyl as street weapons. So we could, but a lot of the police services were like, we're not on board with this, right? So, so when your provincial government's health initiatives are really criminal justice focused, and then even your enforcement is like, what are you doing? It speaks to the distance that these decision makers are from the research evidence. So I think part of what I wanted to talk about too is that this is happening at a time when we're seeing major cuts to our social service supports, which is impacting housing as well. So in Saskatoon, as one example, even after the pandemic, we saw in 2018 we had approximately 475 individuals identified as without housing in Saskatoon, which is still far too many given the size of our city. In 2022, that had risen to 550, so an increase, but not all pandemic. We then had a major change in our social service allocation for housing and the way that was administered. And many advocates said this is not going to go well. They basically wanted to remove the role of trustees for those who were seeking support. And so they went ahead with that despite objection. And in our most recent point in time count in Saskatoon, we now have 1,900 people without housing in a very small city of about 280,000 people. So, so these cuts have been across the board in many ways, not only related to harm reduction, but also basic social service supports. And it's very challenging to try and stabilize an individual's situation when there is no housing, when there are not harm reduction supplies, and when you're basically going in the direction opposite of what best practice evidence says should be done. The visits to Prairie Harm Reduction and the supervised consumption drop, along with the drop-in center, have increased a lot. In 21-22, we had 577 unique people accessing the supervised consumption site in Saskatoon. In 2025, that was 1,042 people who were accessing the site. So we've seen major increase. Partly, this is because folks in rural and remote communities in Saskatchewan are coming to urban centers because they've been told there are services in urban centers. And so this is a barrier that's being faced by many in the province. The city of Regina is seeing similar things, along with the city of Prince Albert. I would overall, I'm really trying to loop it into hepatitis C as the topic of this conference. And one of the things talking with people before I got here is I was sort of going, what are we doing about hepatitis C? And by and large, the response was, we're in emergency response mode. We're in a triage mode right now, and hepatitis C seems like a topic that is too far away to address at this time, as we see these spikes in immediate and acute harms. So it's not that it's not important, it's absolutely essential that we address this issue, but there are a lot of concerns about what is the most pressing thing that we need to address first. Most recently, of course, in Saskatchewan, we've seen Bill 48, the Compassionate Intervention Act, following in Alberta's footsteps, which is going to implement a system of involuntary treatment for people who use drugs and deprive them of their liberty and autonomy. It's poorly written legislation. If I was teaching a policy class in the School of Public Health and had this submitted as an assignment, I would fail it and ask for a resubmission. So harm reduction is in trouble in Sask, and Saskatchewan is in trouble because it doesn't have enough harm reduction. One of the things that I try to remember as we're in this work, I know it sounds very, very hopeless, is that harm reduction has always been a grassroots movement. Harm reduction has always been founded in community. We have that resistance in Saskatchewan, and we have that across the country. So I mentioned the SCS had never been provincially funded. I know that Ontario's under threat of cuts, as is the rest of the country. Seek donations. Seek your community. They will step up. The Broadway Theatre, an independent movie theatre in Saskatoon, provided $10,000 in popcorn sales to support the supervised consumption site. In this one-to-one move, needle exchange move, we've also seen, supporting businesses. So folks who run a Botox injection clinic have been taking their used syringes and ensuring that they're there to be exchanged for people who use drugs. Okay? There are ways around it. So, I think my real message today is that, we might be facing attack, but harm reduction has always been grassroots. Community cares for community, and we can fight back by supporting each other, by holding our politicians and elected officials accountable. Absolutely, phone every phone number, write every letter, show up at every rally you can. But at the end of the day, it's also about doing what we can do. If you have the resources to support, do that. If you can donate $5, that's wonderful. If you can make a sandwich and distribute it to someone who's hungry. We need every single person to step up and do what they can when they can do it, and it will get better. So don't forget the grassroots. Don't forget that we can make a difference even when it feels overwhelming. The fact this panel is happening is hopeful, and people in Saskatchewan are like, wow, you're going to Toronto to talk about this issue. That's really important, right? So just being here today and having this dialogue, it matters. Be sure to share with your friends when you get home.
Thanks so much, Barb. So that was a little bit of stage setting about what's happening in some different parts of the country, some really important messaging around the evidence that we have, that the evidence is not enough to be informing and making the policies that need to be made, and a really hopeful message from Barb about some of the lessons that we can learn from the grassroots in Saskatchewan on how to keep this important work moving forward. We wanted to take that big picture and bring it down to the front line a little bit. So, Doug, I'm wondering, as someone working on the front lines, can you share what it's been like to support people trying to access harm reduction services and hepatitis C prevention services in this newer, different political context in Toronto?
I did write notes as well, and I will also not read some of them.
Doug, do you mind bringing the mic a little closer? Thanks.
I did write notes, so I won't read totally from my notes. I'll go, like Barb said, from the heart. I love my work supporting people where to get harm reduction supplies to testing and treatment and whatever they need at the time. We need more services, not less, for people who want to not use drugs or alcohol, vice versa. They provide low barrier access to healthcare, housing, support, mental health, and run daily programming. And it's done by a lot of peers. And staff are very supportive at meeting people where they're at. We can't abandon anyone, no matter where they're at. With their use, this means offering the full continuum of substance use, health care, from supervised consumption sites to detox and withdrawal to inpatient rehab. Everyone has a different journey towards wellness, and we need more options, not less. And they need to be run in the way we do all our services, with respect and dignity, never judging a person. They are currently huge wait lists for detox and rehabs, and I'm sure you all know because you're here today. Complicated, difficult for people who want these services. Workers are often making calls to detox with service users who are told that there's no beds are available. Yeah, and keep up the fight, yeah? Got to just keep fighting.
Thanks, Doug. Martin, as another frontline leader in Montreal, how has the political environment and policy changes impacted community members and clients at Dopamine?
Well, we are sorry for the collective depression, but I think those conversations needs to happen, and we need to share that. They talk, we die, right? This is not only a slogan from our grassroots organization. While politicians debate harm reduction, our people face death every day. It's also increased stigma for people that use drugs and create even more barriers to access other services, like housing, right? Housing's tough all across the country. But especially if you're labeled as a drug user, it's even more tougher. Even in Montreal, the access to the emergency shelter in this strong winter that we have is harder because you have the stigma or the label that you use drugs. For Dopamine, opening a supervised consumption site should not feel like a political battle. It should feel like implementing evidence-based healthcare program. We should have more support than barriers to open those services, and unfortunately we're not. And well, concerning HepC, every delay in opening new services or having difficulties to give people harm reduction supply is not a neutral. It's an epidemiological consequence, important. It also means fewer opportunity for testing, fewer chance to connect people to hepatitis C treatment, and more people at risk in our communities. Yet in this climate, we feel often that we have to justify every move that we do. When access shrink, infection rise. This is not ideology. This is simple math.
Thanks, Martin. All right, so we're going to move now into a bit of a discussion around opportunities to increase access to harm reduction services. And we really wanted to make sure that this was a broad discussion and it includes the role of researchers and the role of clinicians in trying to change policies. Ahmed, starting with you, as a researcher and someone who contributes to the evidence base around harm reduction programming, and you shared some of those figures with us earlier, and the impact of services and service closures, how are you thinking about the current political climate and the role of researchers and evidence and physicians in affecting change?
Yeah, I think I misspoke earlier, by the way, when I said 4% for HCV, I meant HIV. But to your question, Rivka, I think, I think a lot of clinicians and researchers have for a long time thought that the answer is to have good evidence and better evidence, and that would lead to good policy. I've been an expert witness on 2 charter challenges recently, one of which was filed, one of which I can't tell you about because it hasn't yet been filed. The first one was around the closure of the supervised consumption sites. And my affidavit and the briefs of the other expert witnesses, both from both sides, are all available on the HIV/AIDS Legal Network website. But if you're interested in sort of what the evidence is and what the evidence says and how people think about the evidence, I invite you to read those affidavits. Like, there is a lot of evidence for supervised injection sites. It's almost all observational evidence. So we can have lots of discussions about whether that's a sufficient evidentiary base for policy or not. But there's very little evidence actually against it. Like, if you read the government affidavits, they're surprisingly evidence-light. This is my biased assessment, but you can make your own judgment because these are available documents. But and I do want to stress, if you go back to the original Supreme Court case that said that Insight should stay open, they cited the evidence that was available at that time, and they accepted that evidentiary standard for keeping Insight open. So in my estimation, and there have been several systematic reviews, all of which have said, the evidentiary standard is this. And yet that has not changed policy. And yet, so I don't think just more evidence or even better evidence is sufficient. So then, some people have said, well, the next tool in our armament is a legal challenge. And so we had this case. I was an expert witness. The final decision actually has not yet come down. It's been months and months now. But there was an injunction. The injunction said that the government could not force the sites to close. And yet, only one site stayed open because they had private funding. All of the other sites closed because they didn't have the funding to sustain their operations. And in fact, they were threatened with removal of other funds if they didn't close. So, and actually I was talking to one of the lawyers that I've been working with, and she pointed out that governments are very willing now to invoke the notwithstanding clause, which is this uniquely Canadian and uniquely unfortunate approach to policy where even if you do something unconstitutionally, you don't like it, you just use your get out of jail free card. Right? So like the role of using the law to change policy, I think is actually pretty restricted. And that really, I think, leaves us with politics. And it's somewhere that, something that I think many clinicians and researchers are uncomfortable with. But, you know, if we think that this is the correct policy based on our evidence, it's pretty, the only conclusion that I can see is that we're going to have to engage somehow in that political process. And I want to emphasize, too, that this is, I'm not just talking about partisan politics, right? It is a Conservative government in Ontario that has brought in many of these changes, Conservative government in Alberta, but it's a Liberal government federally that has backtracked on a lot of these things. It's an NDP governments in Manitoba and in British Columbia that have backtracked on harm reduction. So I'm not saying that this is a partisan issue, but engaging at a political level, I think, is an inexcusable and necessary next step.
Thanks so much, Ahmed. A perfect segue to hear more from Barb. You're very aware of the privileges that you have as a researcher when it comes to speaking out publicly. Can you share some strategic collaborations with community in influencing policy and strategizing on pragmatic workarounds in this context? And what would you say to other researchers in the room about opportunities to influence policy?
Absolutely. And I think, you know, I've often said, you know, I'm privileged because in my job as an academic, I am free to speak in alignment with the evidence. It's, in fact, I see it as not just a privilege, but my responsibility to share that evidence base. But as we've heard, all the evidence in the world doesn't seem to be changing minds. So I think it's important that those of us with professional credentials speak as often and as loudly as we can, recognizing that not everyone is free to do so. I often receive phone calls from, you know, Saskatchewan Health Authority professionals who are like, thank you for being on CBC this morning and talking about this, because I can't speak that way. Or there is a fear that they will be in trouble in their employment role if they do. So we do need to speak as researchers about that evidence as often as we can. Make time for media, make time for community events and meetings. You know, when my member of parliament last week showed up and wanted to talk with businesses about the supervised consumption site and its role in our community. This has been a strategy at the federal level that they're rolling out. We showed up, and not just myself, certainly, but many community members. 70 to 75% of that room who showed up for that conversation was in support of the supervised consumption site, right? So people took time to show up and be present in community. And that's a really important strategy that I think we forget when we're, you know, when I'm on my Facebook and I've got my nice echo chamber. It's nice, everyone agrees with me and my worldview. But we need to get out and meet with people, you know, in the community and in real life. We need to make this evidence as relevant as we can to the communities that are concerned, right? So one of the things I heard at this meeting the other week was, you know, people are very concerned at the presence of individuals who are unhoused in the community. They're worried about vandalism. They're worried about the lack of public restrooms. They're worried about a lot of things that are not about the supervised consumption site. But that supervised consumption site is visible, right? And so it gives this it gives a target in some ways. So hearing voices about how we can solve those problems that people are identifying and taking those problems seriously and talking about it together gives a pathway forward. So I think one of the strategies I suggest is being present in community, taking the time to build those relationships with frontline providers, with the organizations that are doing this work that is so foundational to people's health and well-being. And booking appointments with your municipal leaders, getting to know them, especially if you're in a role like I am, where, you know, I read evidence all the time and I say, hey, would it be useful if I summarize some of this evidence for you and put it into a one-page brief that you can then learn from and take into your next meeting? We need to share this information more broadly and in ways that are not traditional in the academic industry, in a sense. We write a lot of journal articles, and, you know, I can't I can't even get my students to read all the journal articles, and they're paying a lot of money to do that. So, so expecting that the general public is going to suddenly, be able to access this and read it and take that time is not reasonable. We know everyone's overworked. We know that sort of thing. So as much as we can partner with people, and of course, as an academic, I am not the best positioned person to maybe provide information to members of the community. People who use substances are best positioned to say what is most relevant and what people need to hear about. And working together, when we're all at the same table, we can create some real impact. That's really important. And I know folks are like, but how do I do it? And I'm like, send an email, call someone, have a coffee together. You'll be surprised at how much you share in common when you take that time, 30 minutes, to have that coffee. You might start a revolution, And I think we also need to be ready to, and I mean this with, no, I mean it from my depths of my heart. We do need to shame our decision makers who are not following that evidence and hold them accountable for the decisions that they're making. The fact there are more unhoused people in Saskatoon right now is the direct result of poorly done policy. Hold those decision makers accountable. When the NDP in Saskatchewan did not oppose the compassionate intervention bill that is so poorly written in its first reading in December, yeah, we got mad and we reached out to, and to her credit, the Shadow Minister for Mental Health and Addiction said, yeah, I want evidence. I want to know what's wrong with this bill and how it could be improved. But there was a lot of fear amongst the official opposition. Well, if we oppose this, will it create a wedge issue? It should create a wedge issue. Do your job. They hadn't read the legislation before they voted on it in the first round. So now they've read that legislation, they've had it summarized for them, they've had it presented back, and they're hopefully reconsidering their stance on it. But we need to encourage that kind of political engagement. We need to encourage our decision makers to do their job fully and completely rather than skimming over the title of a legislative act. They should be reading it, right? So don't be afraid to hold people accountable who are in these power positions, in these decision-making roles, and be sure to reach out to your communities around you to see what you can do together. All revolutions started with 3 people in a room having a conversation, so let's keep that going here in Canada.
Not yet, sorry. Thanks so much, Barb. And I think it's a really great, so many great threads to piece together on the panel. And I think, hearing that at the recent hearing, 75% of the people in the room were in support, is something that we can all remember when we're, reading so much negative news media and commentary around harm reduction.
Every fiscal conservative should 100% support harm reduction. Every single one. So,
Martin, you have shared that you're in the process of trying to open a new supervised consumption site at Dopamine. In the face of this context, what has kept you grounded in your work, and how are you thinking about and continuing to evolve harm reduction and hepatitis C services to effectively meet people's needs amidst this political climate?
Yeah, it's important to keep ourselves grounded and to push together. For me, it's simple. What's keep me grounded is I am accountable for the people that walks through our door every day. Dopamine receives more than 30,000 visitors every year in our different program. Connecting with each other as we do today is also keep me focused. It's important to get out there and to speak about the reality, but also about what we need to do to move forward. Peer worker are public health leader. They are not program accessories. We really, our peer-led program really helps me to keep me grounded as well. Our holistic approach to have a medical clinic, SCS, drug checking program, food, laundromat, shower under the same roof, and to see the person as a whole person, and we have to treat people with dignity and respect. That really keeps me grounded as well. Taking the time, we need to get out of the emergency mode. We need to develop a relationship. This is the key to achieve our goal on my perspective. If hepatitis C elimination is truly a goal, then we truly have to support harm reduction. We have to protect our program, we have to fund it properly, and we have to secure them to move forward. Thank you.
Doug, there's been a lot of difficult news lately when it comes to harm reduction services. But we've also know that there's some positive stories related to some developments in Toronto and in your own work. Wondering if you can help to highlight some of those today.
I can. One of the positive is, you can hear me? One of the positives is that our Moss Park safe injection site has got a year extension, but it also comes with a uncertainty, because if the builder decides to build, then we have to shut down. But the good news is we got an extension on it. Other good news is we're working with the prisons, thanks to PASAN organization. We're able to, I was also incarcerated with Hep C and never was able to get treated when I was. And now they're able to start people on treatment, which is great. That's another good thing. These heart hubs, yes, they are also another great program if they're staffed with people that have the lived experience and that, you know, are going to support everybody with dignity and respect. I know the one that we have, the staff love doing the work. So yeah, I think they stole the name from the safe injection sites, because they are the true heart hubs. They build community. So yeah, that's the good news I have. Not much, but yeah. Very pleased.
All right. Thanks so much, Doug. Last question, Jason. A big question. Can you contextualize what you think about the impact of changes in harm reduction policies and what they will do for hepatitis C elimination efforts, and what people working in a more hepatitis C space need to understand about the changing landscape? And how do we deal with a new environment or political landscape that has a growing sense of disconnect between population and public health discourse and harm reduction?
That's a little question. And with a little bit of time, so I'll be quick. I think there's some things we really need to pay attention to in terms of the rollback on harm reduction, and there's some obvious things that probably everybody has top of mind, but we do have to pay attention to what it's going to do to some of the core things that we did have success with HIV. Like we're going to see changes to how people use drug-using equipment, share drug-using equipment, how they access those things, and those changes need to be examined and paid attention to very closely if we're going to be serious about Hep C elimination. We're going to see potential losses to linkage to care and treatment as a result of these changes, less opportunities for that, and we need to pay attention to those things. And we got to pay attention to reinfection rates. So those are the three things that I think we can anticipate. We need to pay close attention to based on the rollback of harm reduction. I also think we don't have an evidence problem. We do have a populism problem, a polarization problem, and a punishment problem. And those things are defining this space, not the evidence. And I think to the other comments, there have been really great suggestions, so I'm not going to repeat them, and some of them are the same. Some of my comments on this are the same around how we shift this. But we also can't stay in a polarized crisis space. We're in a room where we're assuming some agreement on things. We don't probably have as much agreement as we think on all of these things in this room, I'll be honest. So that's the other thing. I think we have to find the things we can come around and agree on to advocate for collectively. And we have to have our disagreements honestly and respectfully in a way that don't shame each other, but allow us to build coalition in these spaces. So where we do have disagreement, we have to have spaces for those conversations. We have to do that for ourselves. We also have to recognize that the context we're working in is one where polarization, shame, and punishment are driving not just the approach to people who use drugs, but the people who support people who use drugs, the services that are being built up for those people. I don't know if you guys follow the local news in Vancouver, but like there's we have a party system in Vancouver in municipal politics, which is not common everywhere. But there, in the last week, there have been allegations made by people in the party that is in leadership against the few opposition party members, that on Christmas Day or over the holidays they were using drugs and distributing free drugs to people on the streets of Vancouver. These are false allegations, but they were said by a particular city councillor who's since retracted and apologized for the statements. And then it came out yesterday in CBC that allegedly it was the mayor who actually first made those allegations, and he has not apologized for them. There's a reason people are doing this. It's effective. There's a reason people are using these tactics. And so as we've come out of a period of crisis, this is going to keep us in crisis. And so our responses become embedded crisis responses. We're not as organized as we need to be. We're not telling the stories we need to, because we're constantly responding to crisis, whether it's in courts, in the media, in neighborhoods and communities. And I think that is not a place of strength for us to be working from. And we need to get to a post-crisis space. There are approaches to this that we need to really think about, and they aren't about, we do need the evidence. We need more publications, we need the evidence. What we do with it in the popular sphere really needs to ramp up and mature and evolve into something that will change a society that is tired of giving things up for population and public health. There is a perception that harm reduction means giving something up, whether it's a perceived or real sense of safety, seeing drug litter on the streets, whatever that is. Those things are driving policy decisions in this country right now in a way that we're going to see huge impacts on Hep C care and infectious diseases generally, but in harm reduction. And we have not countered that well, and part of it is because the sector has been in crisis, and responding to crisis is exhausted by crisis, and we need to do the work to lift each other out of that and combat those messages effectively. It is not an evidence battle; it's a political and populism battle.
Thanks, Jason. And a great reminder by Ahmed earlier that it's not just one political party either, it's across the board. All right, we have a few minutes, Jason, for your question.
You started late.
So first of all, I'd just like to acknowledge everything that you guys have been going through on the front lines, and just thank you for everything that you guys are doing. It was a really fascinating discussion. Oh yeah, I'm Jason Grebley from the Kirby Institute. It is interesting. It's irrational. It's not logical, not based on evidence, sort of the responses by the politicians and policymakers. But I do wonder, in terms of a proposed solution or one idea for one, is I don't think that we're doing a good enough job at accurately depicting the cost of these negative actions. And I think making the investment case or the anti-investment case of the costs of what these decisions will make, and then arming the community with the voice to bring this to government. I also think we need to sort of understand better from a policymaker perspective what sorts of things they want to see and what would influence decisions around some of this. And it may go back to the same problem that the evidence isn't going to change things, but at least you're presenting a case around this is what it's going to cost. And maybe it's the general public that needs to be educated to then push up. And it's this sort of mobilization and community action together to push that messaging up. And, even stuff like what Natasha Martin was doing. I mean, Natasha mentioned it this morning, but around, modeling the impact of addressing houselessness, and taking that sort of a thing. So I'm just wondering whether we can be doing better with the research and evidence on that front, but from an investment case perspective and presenting it in that way to government, and whether that might resonate. I don't know whether it would work. You guys. So does anybody have any thoughts on that is the question.
All right, I'll just jump in. Yes, I agree. And we do need to keep investing in creating that evidence base. So my team in Saskatoon recently just completed a social return on investment analysis of the supervised consumption site in Saskatoon. And yeah, for every dollar invested in that site, we see $4.44 in social and economic value returned to the community. So that kind of thing, it'll be published in Frontiers shortly. So these kinds of things, so that we can argue for the cost value. I mean, I wish it was that we cared about other human beings, and so therefore we just invest in these services. But yes, there's definitely economic argument to be made, and as far as I'm concerned, attack on all fronts is the best possible strategy. Yeah.
So briefly, I do cost effectiveness analysis. So for sure we need economic analyses, but most economic analyses are done from a societal perspective. The governments actually don't really care about that. The governments mostly are focused, especially now, these governments, on their own costs, right? And if they can shift costs, and that's a win for them, right? And quite frankly, when people die, they don't cost money, right? And that's the kind of economic calculation that governments are doing. Like in the Canadian situation, at least, we use cost effectiveness analysis for things like deciding whether we're going to fund Hep C drugs. We very rarely use cost effectiveness to decide about public health policy or social policy. And I mean, I've had these conversations. I used to sit on the Canadian Drug Expert Committee, which advises governments on which drugs go on formulary. Like, I think I do have a good understanding of how governments use and don't use economic evidence. They just are not going to use the economic evidence here. We need to generate it because it is part of the evidence base, but it's not going to be sufficient to change policy.
I would agree with that. I think it's the floor that we need to even get in the room for the conversation. I don't think right now it's actually shifting a lot in terms of decision making. And I think part of that is, again, it goes back to the populism. I think people are actually quite willing to spend more or spend on more expensive options if it removes visibility. Like if incarceration is expensive, people are probably pretty supportive of that for street involved and homeless people using drugs. And I think most governments are willing to take a bet on that from a winning the next election thing. I think it's very clear that the NDP government in BC knew that that to stay in power, they had to back off decriminalization and back off other harm reduction stuff if they wanted to stay in power, and stop another good policy, which carbon taxes. Like, they weren't going to win the next election if they didn't back off good policy. And so I think they're making those kind of calculations. That's an opinion. But I do believe that there is actually, there's a degree to which people might be willing to spend more on things that take this out of the public view and take it out of sight and out of mind, even in the face of austerity, and even in the face of budgets that don't really have the money for it.
Sorry. So when you say cost effective, wouldn't that be like pretty much me from going from homeless? Sorry. Yeah, it is cost effective because I went from being homeless to house to off of ODSP to working full time. So it would be cost effective.
Hi, Natasha Martin, UC San Diego. Jason stole my question, but it offers me the opportunity to ask a different question. So I come from the U.S. and I'm here to express my solidarity. We obviously have a public health system that's being dismantled. We are now not even allowed to apply for grants or say the word harm reduction, which will be devastating for both, obviously service provision as well as research, and supervised consumption sites are still illegal. Okay, and I was going to ask the economic question and what impact that would have, which has been discussed. So I have a secondary question, and that is about the comment that you mentioned that we're coming at, there's so many policies, and it's intentional. All of these different policies together, we're overwhelmed by it as an academic and outside community service provision community, and it's I feel personally it's paralyzing me in terms of figuring out how do I effectively coordinate my own research, and how can we as a research community coordinate our efforts so that we can each take pieces of this to kind of effectively attack. We have so many different policies that are under attack. How do we, I'm a modeler, a health economist like Ahmed, how do we model, simulate, do we do it in in isolation? Do we do all of these policies together? But this is a general question, not just about modeling, in terms of how we mobilize effective research in this environment as a community to have the most impact. It's sort of an open question.
Everyone's looking to me. Yeah, okay. We're going this way. All right. This is a wonderful question, and I think that's really what venues like this offer, some opportunity to start that dialogue and move forward. Finding allies has been critical, at least in Saskatchewan. If I can parallel some of that solidarity to where you're at in the States, it's challenging, even more challenging, I think, than what we see in some of our most conservative provinces and provinces that are meeting it with austerity. I think my first thought was the Canadian era under Stephen Harper, when he was our federal prime minister, we couldn't say the words harm reduction either for a very long time. And so everything became prevention. So use that language strategically. Is my best advice. Find the folks who are doing the kind of prevention that you would like to be doing, because it will keep moving. Keep moving forward. My other thought is when I said find your allies too, one of the success stories we're starting to see in Saskatchewan is that municipal governments are fed up with paying for health system failures through their municipal policing costs. So our provinces pay for health, but the municipalities pay for policing. And those policing budgets are now almost half of the municipal budget in many cities. So when it was pointed out that, hey, the failure to provide health services for substance use is being downloaded on a municipal policing budgets in Saskatchewan, suddenly the municipalities were like, yeah, that's true. Hey, we are paying for this health failure. How can we put pressure back on the province to advocate for these health services and get them reinstated? So it was sort of like we found this common ground, and now the Saskatchewan Urban Municipalities Association is behind it, and many of the municipalities are like, yeah, this province should be held accountable for their lack of health programming on this topic. So sometimes hitting that budget pressure point, I guess, can lead to some solidarity. But to find out so many municipal leaders were very, very supportive of enhanced health services, of harm reduction services. Also, they're the ones who are closest to the ground. So even though they're not responsible for health in the province, they certainly hear about those health failures, I think maybe more frequently than some of our provincial representatives. So find your allies and be picky with language is my two strategies.
Thanks, Barb. Just mindful of time. Any final closing comments for this?
So I'll be really quick. So I think three things, Natasha, that I think of. One is, I think we should also be thinking about new modeling approaches and then not just doing modeling the way we've always been doing it. There's like community-based system dynamics modeling that we started to do that I think it tries to get at some of these real complex interrelationship between issues, and also really brings in the community perspective. So Doug and I are working on a project with that together, which has been challenging, but also really fun. Yeah. And the second thing, I think breaking out of the usual way we do things. Second, I would say, the social sciences actually has a much stronger tradition of public intellectuals. We in health research generally don't have a very good model of what it means to be a public intellectual, and I think we need to really break the way we're doing things and think about what does it actually mean to be a public intellectual. That's a huge discussion, so I'm just going to leave it there. And then the third thing I would say, I think, as Barb was saying, these sort of advocacy coalitions are really important, but fundamental to that is, as researchers and as intellectuals and as academics, we need to think about our power relationships in those, and we need to voluntarily cede power, right? We need to recognize that we are not the experts in advocacy, that we are not the experts in moving things forward in ways that they need to be moved forward. So we are part of that, but we're not going to lead that. Very few of us, I'm not going to lead that. Very few of us are going to lead that. So, but we do have tremendous privilege. And so voluntarily thinking about how we go into that consciously and voluntarily give up power, and how we think about those power relationships deeply is critical.
Thank you so much. All right, well, I wish we had more time to continue this conversation, but unfortunately we are out of time. So please, I encourage you, if you have any questions for our panelists or want to continue this discussion, to feel free to approach them after this session. I want to thank CanHepC and the symposium organizers for inviting CATIE to curate the panel today. Thank you so much to our esteemed panelists for sharing your insightful, impassioned reflections on this critical topic of harm reduction and hepatitis C prevention. We're incredibly grateful for your time and for sharing your expertise with us today. And thank you, everyone in the room, for being part of this conversation. All right, we have 2 abstract presentations, everyone. Please stay where you are. So I am pleased to invite Jeong up to present on sex-specific patterns of cardiometabolic and renal complications by ethnicity among people with hepatitis C in British Columbia, a population-based study.
Thank you for the introduction, Rivka, and I'm not sure how I'm going to follow after this panel, and my presentation is on a completely different topic, but I wanted to take a moment to just say that I really appreciated all the amazing work that the panel has been doing, but especially Doug and Martin for really highlighting the resilience of the community and the dignity of the community, and also to mention that we have Downtown Eastside Crew, which is Community Research Ethics Workshop. We have all 4 authors from Vancouver, Downtown Eastside, attending the conference, and they have a poster presentation on at poster number 92. So, and presenting on how community and researchers can collaborate to really advance, to improve health disparities and to advance health equity. So please take a moment to visit the poster and talk to crew. You guys just say hi to people. All right. Oh, okay. All right, I will have to proceed without my notes, which is okay. I will like to begin the presentation by acknowledging that this work was carried out on the traditional, ancestral, and unceded lands and waters of the Coast Salish peoples, whose relationships with the place stretch back since time immemorial. I would also like to acknowledge the lands that we gathered today are based on traditional and treaty lands of the Anishinaabe, Wendake, Nonsiu, and the Haudenosaunee. I'm so sorry about the pronunciations. I would like to acknowledge that this work is based using data on a lot of the people that live in these lands, and we really hope that this respects the overall health of individuals represented in this work. So I will just start with the background. Hepatitis C is often thought of as a liver disease, but 74% of individuals living with chronic Hep C will experience symptoms other than liver disease, so stroke, cardiovascular events, diabetes, or kidney disease. From our previous work at the BC Hepatitis Testers cohort, we saw that there was a high burden of metabolic disease in South Asians living with chronic Hep C. So they were at greater risk of type 2 diabetes and also a greater risk at chronic kidney disease and end-stage kidney disease compared to people of other ethnicities. What we don't know is what is the interaction between the ethnicity and sex gender, and how this might impact the risk of these cardiometabolic disease related to hepatitis C. So that's what this study tried to assess. We are using the BC hepatitis testers cohort, which is a linked administrative data, and we include people who were diagnosed with hepatitis C from 1990 to 2015 and assessed outcomes up to 2021. So for the analysis, we included over 40,000 people and then divided by treatment groups, so untreated, treated, and then we also included those who spontaneously cleared to look at the risk of the metabolic disease, cardiometabolic disease, among those who actually didn't develop the chronic infection. And the outcomes assessed were incident type 2 diabetes, the renal disease, stroke, major adverse cardiac events, and all analyses were stratified by sex gender. So before going into the results, I'd just like to highlight the baseline characteristics of individuals who are included. So South Asian women who were untreated with chronic Hep C had a median age of 60 at the first diagnosis of hepatitis C in British Columbia. 74% were living in areas with greater deprivation, which means that this represents like area of lower income and lower education and employment to population ratio. So, and they also had a higher baseline diabetes. For East Asian women, this group represented actually greater proportion of this group who were untreated. Were also a bit older at first Hep C diagnosis with a higher diabetes, prevalent diabetes compared to women of other ethnicities. So I just want to highlight here the median age that we're looking at is the age that people were first diagnosed with hepatitis C in British Columbia. That doesn't mean the age that they actually acquired infection. So for example, for South Asian women, the median age of 60 means that they might have been living with a undiagnosed hepatitis C chronic infection for a long time before they were first diagnosed. So with that, first looking at type 2 diabetes, the incident diabetes was highest among South Asian women with 22.7 per 1,000 person years. This is almost twice higher than incidence in South Asian men, twice as high compared to incidence in East Asian women and men, and almost 4 times higher than incident diabetes among women and men of other ethnicities. For renal disease, they also had higher incidence rates among South Asian women. And when we're looking at hazard ratios, we saw that the risk of getting incident renal disease is almost double the risk in South Asian women compared to women of other ethnicities, while their hazard kind of attenuates after treatment. So for renal disease, the disparity resolves after treatment, unlike diabetes, which we will see a little bit more here. So this is hazard ratios showing the hazard of getting diabetes among women, so among women and men for South Asians. So this is looking at the risk in the same sex gender. So for the line, the hazard ratios in orange, these are for women, comparing the risk of South Asian women compared to women of other ethnicities, and then for South Asian men, this is their risk compared to men of other ethnicities. What we see from this slide is that both South Asian men and women have greater hazard ratio of getting diabetes compared to other people of other ethnicities in the same-sex gender. But there is a different trend. So South Asian women have even greater ethnic disparity of getting diabetes. So why does this diabetes risk persist? First, there might be some underlying metabolic risk. So we saw that there were a greater proportion of South Asian women who had type 2 diabetes at hepatitis C diagnosis. This might mean that they have underlying higher metabolic risk. So could be genetic predisposition or epigenetic factors putting them at higher risk of diabetes. There might also be multiple pathways to creating higher risk for diabetes, such as socioeconomic and cultural factors that continues to affect their risk for diabetes. And lastly, it could also be that South Asian women were diagnosed late and treated late. So the window of time for reversing the effect of hepatitis C in preventing diabetes might have already passed by the time that they were diagnosed and treated. So this showed that in our cohort, the type 2 diabetes disparity was not resolved by hep C treatment. For stroke and major adverse cardiac events, both South Asian women and men had a little bit higher hazard for getting these before treatment, but these attenuates after treatment. Same thing for cardiovascular events as well, which shows that unlike diabetes, the risk for cardiovascular events resolve after treatment. So I want to briefly highlight the patterns in East Asians because this differs quite a bit from what we see in South Asians. For East Asian men, they had higher pre-treatment diabetes compared to women. So this is actually reverse of what we saw for South Asians. Also, we see that after treatment, their risk kind of attenuates. And then for cardiovascular events, we see that in all treatment groups, their risk is actually lower than people of other ethnicities, so hazard ratios below 1 in all of the treatment groups. So this slide is really just highlighting that ethnic disparities in EHM risk differ between East and South Asians, with incidence rates suggesting kind of more pronounced burden in South Asian women compared to South Asian men, highlighting the need for ethnicity and sex gender specific care approaches. So for implications, first, we really need to screen earlier and increase accessibility. So we saw that South Asian women with hepatitis C had diabetes rates 4 times higher than other women. And so diabetes screening should begin at hepatitis C diagnosis with culturally relevant programs for prevention and management designed in collaboration with South Asian communities. We also saw that treatment works, but diabetes risk persists. So the cardiometabolic management should really run in parallel with antiviral therapy for hepatitis C. And we also really need to disaggregate data by sex and ethnicity. So without sex and gender and ethnicity disaggregated data, we would have not seen the 4 times higher diabetes risk in South Asian women, and also that East Asians have really completely different patterns for EHM risk compared to South Asians, and this would have remained hidden. So sex, gender, and ethnicity disaggregated data are really essential for advancing health equity. And lastly, we really need to address social determinants of health and syndemics at the same time of treating hepatitis C, because we saw that majority of South Asian women in the untreated group were living in areas with high material deprivation. So clinical interventions alone are insufficient to address these health disparities. Really need to provide social supports and culturally relevant care to advance health equity in this group. I'd like to end by limitations. I am so sorry, the font is a lot smaller than I thought. Just to mention that South Asian women included in the study sample represent a very small group of each subgroup. So we have large confidence intervals. So estimate need to be interpreted with caution. Secondly, this analysis, we assess sex and gender as recorded in health administrative data. So that probably encompasses biological sex and gender. And we were not able to capture gender-specific differences. So gender-specific risk factors and needs and gaps must be explored further. And ethnicity used in this study was inferred from name-based algorithm. So this was validated in British Columbia with a very high positive predictive value for East Asians and South Asians, meaning that people we identified as being East Asian or South Asian, very highly likely that they actually were. Both were over 98%. But there still remains some misclassification possibility. So especially if East Asians and South Asians were classified as being in other ethnicities, that would have biased our estimates towards the null. So this means that the disparity that we saw is probably as large as or even larger than what it truly is. So the findings are also specific to British Columbia. So, and from our knowledge, this is the first study that looked at ethnic disparities in EHMs by sex gender. So the replication in other settings is needed. So I would just like to conclude that in this study, we saw that South Asian women with hepatitis C faced substantially higher risk of diabetes and renal disease compared to women of other ethnicities. And hepatitis C treatment reduced but did not eliminate these disparities. We also saw that East Asians had a distinct pattern. So it's really essential to disaggregate data by ethnicity, sex, and gender to identify where the gaps and needs are to advance health equity. I would just like to acknowledge that people of British Columbia whose data are integrated in the cohort and for whom this research is intended to benefit. I'd like to thank my supervisors at BCCDC and my colleagues at BCCDC, as well as CanHepC and CIHR for supporting this work. Thank you very much.
Thank you so much. Thank you so much, Dan, for your presentation. Unfortunately, we're out of time. We have one more presentation before lunch, so please hang on. It's a difficult slot to be in. So please join me in welcoming Ciara Eizadirad, apologies if I've mispronounced your name, to join us for a presentation on infusing personal perspective and experience in contextualizing and strategizing hepatitis C care with First Nation people.
All right, I know we're on negative time before we eat, and my stomach's growling, so I know everyone else's is, so we'll talk very quickly. But I don't want to undervalue the knowledge that is here and the incredible space that this creates here. So we'll get rolling, though.
Okay. Hello, Aswell, Annie Bojo. My name is Ciara, and I am an undergraduate student at York University and also a graduate certificate student at UBC in Indigenous Public Health. I'm Stalo Nation and Cree Ojibwe, and I visited in the community to understand and the vision and engagement and transcriptions and sense-making.
Scanos Ruguego, Rachel Nigaso, Montor de Gasanatse, Otia Yoni ni Wagishonte, Ganyek Kiono ni Wagishont. Hello, my name is Rachel Montour. I come from Six Nations. I am a language student and I am also an outreach worker in my community. I carry a lot of lived experience. I lived in addiction for 20 years. And I met Kate during the conversational interviews and joined the focus group and sense-making sessions. And I've just really gotten involved in sharing my lived experience in any way that I can.
I think a lot of people here know that I'm Kate Dahn. I work at York University in the Faculty of Health. I'm from Mississauga First Nation, and my passion is really leaning in to listen to voices in community. So we're just going to talk a little bit about the Catalyst project, the why, the how, the what, and the now what. All right. And we just heard a panel talk incredibly well about all of the barriers that are currently in place. So instead of dwelling on that, we are going to move on to what we did about it.
The how. So this is the research that was done was grounded in and centered on relationality and Indigenous methodology, where we connected through conversational visits with First Nations people across multiple cities, what is now known as Ontario, and the engagement journey that was with Indigenous people across Ontario in both urban and rural cities, including Fort William, Wikwemikong, Sioux Lookout, Mississauga, Six Nations, Thunder Bay, Toronto, and Sudbury. Okay. Initiated with and infused throughout in ceremony and reciprocal knowledge sharing, we built on traditional gift giving that we shared, even small gifts and informational resources. We did this by focusing on relational space of visiting as opposed to an interview space. Through these casual conversations, we focused on comfortable conversations, joking, sharing liver and hepatitis C education, listening to the stories, and explaining how this process of sharing helps guide the research so that we can make positive changes. This happened over 50 interviews, and these interviews took place in around kitchen tables, and in a car, on the land, in a band office, council room, in a hotel lobby, and meeting rooms in restaurants. The conversations were flexible, but we first asked what they knew about hepatitis C, and then if they didn't know anything, we shared information and resources. Then what we would do is we would ask about ideas for what we would help to increase that awareness and support access to the screening, and what stories people had that might help us shape better paths to care. And from these interviews, we have hours and hours of recordings, which we have transcribed. And we also held a focus group with the First Nations community, where we met with the words and the insights that were shared together, and we worked on, and together we reflected on the stories that they were telling us. Then we worked with an Indigenous evaluator, where we were able to do sense making, where we were able to reflect, review, and reshare and connect with the stories that were shared by the community, and how it connected and how this was going to guide us with what the community see as priorities and better to help them understand.
So some key themes emerged, like the recommendation for resources that would help to engage community members in why the liver is so important and why hepatitis C screening matters. And that would help us shape awareness resources in culturally connected and relevant ways. As you can see, including humor is a priority, focusing on positive messages, integrating cultural teachings with holistic approaches. Some people want soft, comforting messages, and some like dramatic and scary kind of approaches. They said, scare me straight or give me butterflies and roses. To engage some people, we need resources that engage many different angles. And insightful tips on where people noticed or engaged with education or information on hepatitis C. A lot of community members said hold sessions, casual conversations like the interview sessions, where it's okay to ask questions and say, I really don't know much about it. Also create curriculum module and resources or events for kids. Intergenerational knowledge exchange is so important. Make posts for social media, offer information and screening at big events, have a mobile unit, more training for healthcare teams, and leadership awareness, both in chief and council as well as their healthcare teams. Here are some quotes that share some important messages. I feel like people are automatically like, it's because you're doing something wrong. That's why your liver is acting up. Maybe just more education and awareness about liver health in general and what is a disease, and that it's not necessarily always self-inflicted, but like how just in general the liver works. We want to focus on a conversation that normalizes talking about things, because our people come from a history of not being allowed to talk about so many things. Folks become blind to it. They've just seen all of those pamphlets before, or they are not digestible. It's too much knowledge, or it's not relatable knowledge. That I think folks don't even think about. I think infographics, more pictures, more culturally sensitive pictures, like way less words, less big, unnecessary words. I think just dial it down. Really small, important messages. And then with that, a positive spin. How can we move forward? Not just, this is your problem to deal with. It doesn't hurt to get tested, right? Even if it's in solidarity, everyone who shows up, let's get tested. And I think that removes some of the stigma, that it's not specific people who need to get tested. That's the messaging that defines how it goes. It's just like word of mouth, and then learning to trust a specific service and then getting messages there. Kind of like, I went here and I promise it's a safe space. These folks did this and this for me. And other people hearing that and catching on to it. You have one life to live. Live it well. Liver it well. Okay, so I lived in addiction for 20 years of my life. I now have about 3.5 years sober. I'm taking language and learning and reconnecting with my culture, but I'm also sharing my lived experience in any way that I can. Working in liver health and Hep C was not something I dreamed of, but I'm so glad I'm here now. It's so important to me to walk into these rooms and carry my ancestors and my community with me. I represent them, and we are more than just numbers on these pages. Sometimes research, really, you lose that human part of it, right? And I like to say, hey, look at, I'm here, I'm harm reduction, walking and breathing.
So that's why we do all of this, right? That's why we're here. That's why we spend hours and hours trying to write these grant proposals. So actually, what are we doing? How are we carrying these shared stories forward? Right now, we're working on submitting or have submitted a Ciara project proposal grant that really focuses on 3 aims. Aim 1, awareness. So all these things that they told us in these conversations, this is what would help us have more confidence around Hep C. That's aim 1. Aim 2 is access. So then how do we take these things that they shared that would improve access for people to actually engage? And then aim 3 is action. What are we really going to do about it in a community setting? How do we build capacity? How do we bring on people that take all of these pieces, all these stories that are shared, and make it actually make a difference within community that is community-led? So prevention is all of these things. We can't just do treatment. You can't just do testing. It's all of it together. All of it's prevention. All of it is activism. And I think instead of always focusing on the harm parts, we really have to focus on the wellness parts. And when we carry that in our heart, our mind, our ears, our eyes, and we step forward in that way, that's really, really how we make a big difference. So huge thanks to everyone, especially Ahmed, who is also a student on the team here, who did these fabulous visuals, and Renee in the back, who helped us with some of the sense-making sessions. It really does take a team to do all of these things, and it's really, really powerful to bring Indigenous students into this space to see how all of you are engaging by listening, and together we really will make a difference. Thank you.
Thank you so much for your inspiring energy and sharing so many different insights with us today. So a couple announcements, and then we're off to lunch, very brief. There's a sponsored lunch symposia that are happening right now, or else the main lunch will be served in the grand ballroom or exhibition hall, which is in the lower concourse level. There's also the Castle Gold Medal lecture and award ceremony. That will be in the Provincial Ballroom North. So it's on this floor. It's at 1:30, so there's still a good chunk of time for your lunch and break. It's on this floor at the back near the escalators. And if you are involved in CanHepC poster judging, that is happening right now. Thank you so much, everybody. Hope you have a restful lunch, and we'll see you after.